Thank you, Mark. It's a great pleasure to be here, to be back in the city where I have been trained and did my PhD thesis and see so many old friends. So I'll start off the session with left atrial appendage closure procedures. And my task is to discuss with you the endocardial devices. So now I have to figure out how it works. Yeah. Okay. So I'd like to start off with a small assessment. So what do you think about a case like this? Maybe we can do it just by raising hands. So this is a recent case I saw. So it's a 74-year-old male, permanent atrial fibrillation, hypertension, previous stroke. At that time not on anticoagulation, intracranial hemorrhage while on rivaroxaban with 20 milligram dose. Now hemiplegic, but for the rest functioning quite okay. MRI of the brain, amyloid angiopathy. So what would you do? So you may have read in the meantime the options. So no treatment, oral anticoagulation, a NOAC, maybe lower dose or normal dose, aspirin, endocardial device plus aspirin, epicardial, standalone procedure, and thereafter no aspirin or no warfarin, or you don't know. So who would go for option 1, no treatment? 2, 3, 1 hand, 4, no, 5, a few hands. So there are a lot of surgeons probably. Now number 6, a lot of hands, don't know. Yeah, that's also possible. Yeah. So that sets the stage for this topic, I would say, that there is a lot of things to discuss. And it deals with the left atrial appendage. So there is data from retrospective analysis, autopsy series, TEE data, that if there is a thrombus in the left atrium, it is in the majority of cases found in the left atrial appendage. And that also set the stage for a large push for left atrial appendage devices. The surgeons have done this for many years already, but it has also put forward the endocardial devices. So these are some of the options we have today. We have the Watchman device, we have the Amulet from Abbott, and we have the Wavecrest. There are other options in development, but these are the ones that have presented most of their data. And today I will mainly focus on the Watchman device because the data we have has been collected with the Watchman device. This is a combined procedure, and I think tomorrow you will see some of this in the skills lab. That is the Lariat device, and that is a combined epi-endocardial approach. And this is the theoretical. This is what should happen. On the left, you see animal data. So this in a dog model, and with time, you see an endothelialization of the device. On the right, you see a patient, and this was 1.5 year post-implant, while the patient was on warfarin during that period. And you can see that there is indeed endothelialization of the device. You may question if it is completely endothelialized, but probably the whole device has a small layer of endothelial over it. And this is the Amplatzer device. It's a different concept. It works with a disc and with a lobe, but also the intention to completely occlude the left atrial appendage. So these are the devices, and what is the evidence? So the data comes basically from the Watchman device. That is the only device that has been tested in prospective randomized trials. And here you see a summary of the largest trials and registries. And in green you see the randomized trials, that is the PROTECT data and the PREVAIL data. And what you see is that in total, especially since the FDA approval in the United States, the number of cases has increased. And so in a year time in the United States, almost 4,000 patients were treated with this device. So the pointer is this one, yeah. So this is the PROTECT AF trial. You've probably seen it before, but I will summarize it for you. So it was a prospective randomized non-inferiority trial of LAO closure versus warfarin. And you have to remember, these were done in patients who were eligible for atrial fibrillation. So this is just the regular patient you see in your outpatient clinic who can perfectly get warfarin or a NOAC, for example. And the endpoint was a composite endpoint of stroke, cardiovascular death, or systemic embolism. And this means hemorrhagic stroke and ischemic stroke together. 2-to-1 design, in total about 600 patients. This is for a device trial. This is relatively large. If you compare it to the large stroke trials, it's very small, obviously. And the average JET score was between 1 and 2, so it's relatively not so high risk for stroke, basically. So this was the strategy they used, and this is also what is now recommended if you would implant this device. Let's go back. Yeah. So you have to give warfarin for at least 45 days following implant. So you can imagine that these patients, you should be able to give warfarin, at least in these patients. After 45 days, a TE was made, and if there was no clot on the device or there was no huge leakage, residual leakage, then the warfarin was stopped. It was continued with Plavix plus aspirin until 6 months, and thereafter aspirin was continued lifelong. So these are the results. What you can see is that the trial met the non-inferiority for the primary endpoint, but if you would split out the results, there were somewhat more ischemic stroke, and this was largely driven by also procedural strokes. After the peri-procedural stroke, the stroke rate was comparable. There were much less hemorrhagic stroke, and so the conclusion was that the efficacy of this device was non-inferior. But still there were concerns, and the FDA recommended a second trial. And this, to come back to this trial, so these were the results. So the success rate was modest, and there were significant complications. So this was the first trial with this device. And then the second trial was the PREVAIL trial. There was a kind of similar design. And what they used a similar approach, similar endpoints. And what you could appreciate is that the operators were improving, so the number of side effects dramatically decreased. And the non-inferiority was not achieved for the overall efficacy. But what you should also bear in mind is that there was a very low stroke rate in this patient category. For example, 0.9% in the patient treated with warfarin. But a secondary endpoint is that after the post-procedural complications, it was non-inferior. So this is a recent meta-analysis from these two randomized trials, including two large registries, the CAP registries. And basically you could summarize this that it is non-inferior with the primary endpoint of all-cause stroke. But however, if you look at ischemic stroke, the Watchman device was inferior to warfarin, and this was counterbalanced by a significant reduction in hemorrhagic stroke. Interestingly, there was also a favor in terms of cardiovascular or unexplained death for the Watchman device. This is a very complex figure. It looks like a spider, but it is basically a network meta-analysis. So I'm not a statistician, but what they did is that they collected all the large randomized trials which were done with warfarin, aspirin, the NOACs, and they tried to figure out if you would do this in this so-called network meta-analysis, you would compare the NOACs to, for example, a left atrial appendage device, so how would they compare? And this is a very busy slide, but let's walk through it. So if you start on top of this, so this is overall mortality, and what they compared is the left atrial closure device versus placebo versus aspirin and versus a NOAC. And what you can appreciate is that the left atrial appendage device is better than placebo, and that is mainly driven that you have more strokes if you give no anticoagulation. However, if you, with the current treatment, which is a NOAC, it is comparable in terms of the outcome in overall mortality. Also with systemic or ischemic stroke. On the other hand, if you now go to the downside, that's the bleeding complication. That is, I can hardly see it from here. So what you can see is that the closure device versus NOAC is comparable to major bleeding. However, on the other hand, intracranial bleeding is less with the left atrial appendage device, and also gastrointestinal bleeding may be reduced. This is a complex analysis, and it is not really a test, the one group versus the other, but it is a way of trying to figuring out, so how would the NOACs, for example, would relate to the closure devices. On the other hand, this will be a trial that may give answer to this. This is ongoing at the moment. This is the Prague 17 trial. And they look at a closure device, Watchman, or the ACP amulet versus apixaban. So I think will be an important trial in patients who have a chest VASC larger than 3 and a high has bled, or a previous major bleeding on warfarin. So this will be a very important trial. So, summary, the left atrial appendage is inferior for stroke prevention compared to warfarin, less bleeding complications, non-inferior for all stroke or systemic embolism, and the procedural complication decreased significantly with time, and implant success also increased. But, no, not but, so this may be an alternative for patients with a contraindication for oral anticoagulation. But if you look at the recent guidelines, so this is how it has been put forward. This is 2012. There has been many studies in the meantime. And still the consensus is that we have to really be careful, and we have to use this in a selected group of patients, and then it is only a 2B class level of evidence B indication. So you may consider it at the moment with patients who have a absolute contraindication for anticoagulation. And these were the reasons for that. So this is taken from the guidelines. So there are no data available for the comparison of a left atrial appendage device with NOAC treatment. And this is nowadays the golden standard, I would say. And there are also no controlled trials evaluating this device in patients who have an absolute contraindication. So that brings us also to the question, in who should you implant this? This is a recent survey. So in the current practice in Europe is that if you implant this, it's usually done in a patient who has a contraindication to oral anticoagulation. But who is contraindication to oral anticoagulation? And what immediately comes up to is patients who have a previous bleeding complication. This is a trial, the Averos trial. This was done in patients who were deemed unsuitable for oral anticoagulation. They were randomized to aspirin versus apixaban. And if you look in the paper, so what were the reasons not to prescribe warfarin? That is, for example, that the assessment that INR could not be maintained in the therapeutic range, assessment that INR could or not was unlikely to be measured at requested intervals. So there are many different reasons for not prescribing warfarin. I'm a luxurious position because I'm a Dutch cardiologist and we have a well-organized anticoagulation clinic. So for me, I hardly see this. But I can imagine that in other countries it may be a relevant issue. And serious bleeding was a very small percentage of this trial. So this is the outcome, and what you expect, that the number of strokes is much higher in the aspirin-treated group. And surprisingly, the number of bleeding complications was similar in the apixaban versus aspirin-treated group. And you have to bear in mind that if you implant a Watchman device, you still have to give aspirin thereafter. So this is something to consider. So these are the typical complicated patients who have an intracranial hemorrhage. So what should we do with these patients? And these patients have not been studied, so there have been no trials or so what to do with these patients. But this is a Danish nationwide cohort study where they looked at the discharge diagnosis and they also looked at the prescription of medication. And they could figure out that there was a group of patients who had an intracranial hemorrhage and thereafter being treated by either antiplatelet, warfarin, or other drugs. And what you could see is that the mortality, so this is a biased analysis, obviously, because there may be reason not to prescribe certain drugs. But what you can see is that the mortality was superior in the anticoagulation-treated patient group. So after intracranial hemorrhage, we usually do not consider, again, prescribing oral anticoagulation again. But in this paper, they say you could clearly challenge this. And this has also been tested now. This is a brave study, I would say. So patients who are having an intracranial hemorrhage are being randomized to either no antithrombotic drug versus anticoagulation, and that will be a NOAC. So this trial will answer this important question, I would say. Another important patient population is patients who are having a gastrointestinal bleeding. That is also the patient population where we would consider putting in a device. And this is the same Danish cohort, but now they looked at gastrointestinal bleeding. And there were several options thereafter, so no treatment thereafter, oral anticoagulation, antiplatelet, or a combination of drugs. And what they saw also in this population, that if you resume, so you restart oral anticoagulation, you clearly have a benefit in terms of survival if you compare it to antiplatelet or no treatment alone. And this is mainly driven that you have a reduced number of thromboembolic complications, and as expected, there is a slightly higher number of gastrointestinal bleeding. But the stroke rate may be important than the recurrent GI bleeding. So what they conclude is that after gastrointestinal bleeding, the benefits of restarting oral anticoagulation outweigh the risk of recurrent bleeding. Again, this is an analysis based on a nationwide registry, but it is an important question, I would say. So these are the trials that will be needed in the near future. This is the ASAP-2 trial, is now in development and will probably start the next year, or this year. Prospective randomized multicenter global trial with patients who are not suitable for oral anticoagulation, and they will be randomized to the Watchman versus control. Control in this population will be antiplatelet therapy. These are the reasons why somebody is unsuitable for oral anticoagulation. I think these are all valid points, although the previous slide I showed you, you might question that you could even reconsider restarting oral anticoagulation even after a serious bleeding. And they will look at the first occurrence of ischemic stroke or systemic embolism. And again, they also use the safety endpoints. So to conclude, ladies and gentlemen, I think the left atrial appendage closure device was non-inferior for all-cause stroke prevention, but inferior for ischemic stroke prevention compared to warfarin. There's definitely less bleeding complication if you put in a device and you combine it with aspirin and you compare it to warfarin, at least in the randomized trials. The procedural success was initially had significant complications, and the success was modest. But if you now look at the recent data, also from the large US registry, there is a low number of complications and a high success rate of implantation. And what is now put forward in the guideline is a reasonable alternative for NOACs or oral anticoagulation in contraindicated patients. The results are not applicable to other left atrial appendage devices, because strictly speaking, it has only been investigated in the Watchman device. And there are no data available for the comparison or the efficacy of any LAA occlusion technique with NOAC treatment. A study is underway now. And controlled trials evaluating left atrial appendage in patients who are truly unsuitable for oral anticoagulation are urgently needed. We can discuss the comparator. The ASAP-2 trial will use aspirin. You could consider a NOAC, but this is what is the field at the moment. Thank you very much.
So one urgent question, perhaps, not to take too much time.
No questions. How would you have treated this patient?
So we were really worried about giving this patient lifelong aspirin. So we decided to go for a standalone surgical procedure.
Okay. So
and thereafter no aspirin.
Okay.
Yeah.
So surgical closure. It wasn't in your options, is it?
It was. Yeah.
Surgical closure.
Okay. Surgical closure.
I would have chosen that.
Yeah, excellent summary. The one thing I would mention, before you stop the anticoagulation for a Watchman, to make sure not only that it doesn't have a leak, but also that it's flush in with the appendage. Mm-hmm. And I have a picture of a lawyer who came to me 2 years out from a Watchman, and and I'd even say the picture you showed doesn't look endothelialized to me, but this was clearly not. It was half in and half out, and the part that was out of the appendage does not endothelialize. It usually doesn't. And I think you have to just really make careful that it looks flush on echo and there's not, because if it does hang out of the orifice of the appendage, it's usually not endothelialized.
So this was the first appendage or the device I saw, and the echo looked perfectly fine and the CT looked fine, but this is how
it's a little scary because there's little patches. Now that doesn't look bad, but the one I have, which I can give you if you'd like, you can see the metal, it's really obvious. It was really, crooked, and it had dislodged a little bit.